Delighted to welcome you into our third, actually, in our monthly series of webinars aimed at the general public to share with you about the work that we're doing here at NIHR. So that's National Institute for Health and Care Research, Birmingham Biomedical Research Centre. So thank you very much for joining today. And it's a hot one, isn't it? It's a hot one today, and we've got computers overheating and all sorts over by us at the moment, I think, and my brain too. But really pleased to see you. I know a lot of people had registered. We have had over 280 people register for today's call or our webinar today. So we are really grateful that you have made time to come along today and attend this for live. We do record them, as you know, and some people are not able to attend, so they'll get a copy of it afterwards. But you've got the opportunity, if you're here live, to be able to speak with our presenter. So welcome, and just before we start going, just do a few basics and say a quick introduction about who we are in terms of the Birmingham Biomedical Research Centre. But first of all, I'm Laura. For those of you who don't know, I'm Laura Chapman. You can see that on my screen as well. And we are going to be talking with you, or the webinar's title today is Seeing What Hurts, Ultrasound's Role in Fighting Arthritis by Professor Andrew Filer. We're going to be recording today's session, and as I say, that will be a great opportunity for the people to watch it, or yourselves to watch it back live and share with other people. And we'll put that on our website, and we'll be sending you information about that after this event so that you know where that is and how you can contact us. So a little bit more about the Biomedical Research Centre. And I'm just moving the slide on. And oops, just to say, this is a part of the series called Your Health, Our Research, Short Talks and Big Impact. And this was the idea from talking with our patient advisory group as well. They wanted to know more about what research was happening. And so as a result of it, we decided to do these webinars so that everyone has access to hear more and get the chance to be involved in our research. So what exactly is the NIHR Birmingham Biomedical Research Centre? So each biomedical research centre, and there are 20 throughout England, is a collaboration between a university and an NHS organisation. And because the funding comes from government's National Health Service research arm, it comes, if you like, direct. And we are actually hosted in Birmingham by the University Hospitals Birmingham NHS Foundation Trust. But we're not just there, as you can see, we've got lots of different partners that we work with as well from across the city and wider. So you can see here, for instance, that we're also working with trusts in Sandwell and West Birmingham, as well as Birmingham Women and Children's Hospital and the Community Healthcare Trust, but also our colleagues at Kew University, University of Oxford and Aston University as well. So although we just call Birmingham, we're much wider than that, and it really gives us a lot of clout in terms of the research we're doing and the interests that we have. We are publicly funded, as I mentioned to you, and as such we are very keen to make sure that we do things for the benefit of the community and our members of the public. And what we're really trying to do is turn those scientific discoveries and translate them into things that are going to be useful ways of diagnosing and treating people. And in Birmingham, the focus of what we're doing is all about inflammation. So we're really looking at how we go about tackling something which actually is the driver for a number of different chronic diseases and things that haven't got cures or adequate treatments at the moment. And so a lot of the things that we look at, although they don't sound like they might be connected, actually are connected because of inflammation. And that's why today's talk is going to be so important. For instance, who knew, perhaps if you're like me, I'm not a medic or a scientist. I hadn't realised, until a few years ago that there was a link between cancer and arthritis and diabetes and liver disease. but because we've got specialists, we make sure that they are specialise in what they do, but also they've got this shared goal of tackling inflammation. So today, what we'll do is offer you the chance to ask questions, excuse me. So it wouldn't be chat, it's called a Q&A section. So if you look at the bottom of your screen, you can see a button that says Q&A. It should look like that, or it might have a question mark on it. And if you want to ask something, at the end, we will have a Q&A session, as we call it, and we'll be grilling Andrew and asking him some of those questions. And we'll try our best to get through as many questions that you might have as possible in the time that we have. We will make sure that we finish on time, because I know you've all got things to do. And I would just like to say, massive thank you for coming along today. And I shall now pass you over to Professor Andrew Filer, who will talk to you about seeing what hurts, ultrasound's role in fighting arthritis. So, Andrew, I can see that you've got a different background onto what I was expecting. But
apologies for the background.
Yeah, I'm sorry. We've had a slight technical hitch, everyone, just beforehand. But this is on behalf of Birmingham Biomedical Research Centre and the work that you're doing for our theme. So over to you, Professor. Thank you.
Thanks very much. Well, I think the slides will do that justice anyway, because they represent the Biomedical Research Centre. So I'm Andrew Filer. I'm a professor at the University of Birmingham, but I also work in the QE hospital in Birmingham, where I'm part of the rheumatology team. And I spend most of my time working with patients with arthritis, running clinical studies and also clinical trials. And I was reflecting on this earlier today and realised I've been scanning patients for 20 years, which means I'm quite an old man now. So what I'm going to do is take you through how we use ultrasound in arthritis. But first, each of the biomedical research centres is made up of themes. So our theme's called the inflammatory arthritis theme, but actually it's not just made up of inflammatory arthritis conditions. We study a range of conditions. So I spend most of my time studying adult arthritis on the left, but I also study, and with other colleagues, study childhood arthritis. So that's a new thing we've started doing in the last couple of years. And the sort of exciting work I'm going to tell you about today is what we've now moved from adult to childhood arthritis, which is going to make a huge difference because they're a very underserved group. It's a much smaller group. And we also look after things called connective tissue diseases. So you might have heard of lupus or scleroderma, and one of those diseases is called Sjogren's disease. And you might have heard of that as the disease that causes dry mouth and dry eyes, but can also cause much more severe disease on the body. So we're specialists in those areas. And really, what we're trying to do with the work we do is understand more fundamental mechanisms of disease. So understand how it works. And I'll show you how we do that today, because the changes that have happened in the last, even just the last 2-3 years, but certainly the last 5 to 10 years, have dramatically advanced what we're doing. They've really accelerated the pace of change. And that enables us not only to understand the disease better, but to very quickly find new treatments for disease. And so the ultimate aim of a lot of our work now is personalised therapy. So rather than one size fits all, it's, well, you're a patient who needs treatment A, not treatment B, and not treatment C. So that's really the aim of what we're doing overall in the NHS. It's really specifically what we do here in Birmingham. So we work very closely with patients. So if I'm going to show you something about ultrasound, I need to just quickly remind you about joints. Goodness knows you've got many of them in your body. You don't really need me to show you your joints, do you? But if we were to do a slightly old-fashioned thing and look in the joint with an arthroscope, this is what surgeons do all the time. This is the kind of view we'd see in a healthy joint. So here's Mr. Healthy doing his exercises. And actually what you see is quite a benign, rather greyish, sort of nice, smooth surface inside the joint. By contrast, if you look in an inflamed joint, and you can see that sort of swelling happening here, that's all the fluid and the tissue building up, then it's actually the lining of the joint, which in this case gets really red and inflamed. It's just as if you'd had a swarm of bees stinging you inside your joint. So all of this thick, goopy stuff, like a bunch of grapes almost, sticking out into the joint, is this surface here getting really, really inflamed and swollen and thick. And actually that's what does the damage. That's what creates all the extra fluid, but it's actually also what damages the bone and the cartilage. It's what does that damage. We can see some of that going on under the microscope. So if I take some tissue out, and I'll show you how to do that later, of one of these joints, then actually this very cool grey lining of the joint really does look quite cool. In fact, these little tiny, strange little lacy work here are actually fat cells. They're your adipose cells, the same as the fat cells that you have under your skin. And that's really what it looks like, very boring and just has a very fine layer. Whereas by contrast, this very thick and red stuff is thick and red because it's full of blood vessels. So these pink things here are blood vessels full of blood cells. And all these little tiny purple things are each individual tiny little white cells. So they're the cells that should be fighting infection, but for reasons that we're getting to understand better and better, they're fighting your joints. So it's where your immune system is doing the wrong thing. It's decided that your joint is something that needs to be removed or dealt with. Okay, that's all very nice. But how does ultrasound help us? Well, ultrasound helps us in two really clear ways. One is that it allows us to see what's hurting, so what structure is hurting, what's the source of pain in arthritis. And the second thing is that it allows us to guide procedures and allows us to do things within the joint. How does ultrasound work? Well, you're going to know this because I bet most of the people on this call have had an ultrasound scan. And you'll have noticed that while somebody, this is my friend Mark, who works for me with our scanner in our room, this is one of our rheumatoid arthritis patients. When you're running the probe over, you can't hear any sound. So ultrasound runs at about 1,000 times higher than you or I can hear. So higher than dogs or bats can hear as well. So ultra means ultra. So if you're into cycles per second, that means mega cycles per second, millions of cycles per second. And what that probe does is it bounces those sound waves into the tissue, and those sound waves reflect off different bits of the tissue in different ways. So the probe not only emits sounds, but it also receives them as well. So it's a speaker and a microphone at the same time. And it does that with many thousands of little individual cells, which are about the size, these little crystal cells are about the size of the human head. So you might have 20,000 of those inside a probe. So it's a delicate piece of equipment. So that's great. That allows us to see what's happening within the joint. And it allows us to see some very specific things. So just in the simplest possible way, I can tell what's happening in a patient, whereas as a doctor using my fingers, I often can't. If I use my scanner, then I can appreciate what might be hurting. So here we've got a normal joint with a couple of bits of bone, a little bit of cartilage covering the bone. And the reason that looks black is because cartilage is basically sponge. So if you think about ultrasound of a baby in a mother's tummy, it's a white baby floating around in black fluid. So water on ultrasound is black. Cartilage is rather like a watery sponge. Over here, this stripy thing that looks like a piece of plastic is a tendon. So you can see this really clearly in ultrasound. If the joint gets swollen, then it literally bulges up. So just like in that swollen knee before, this stuff is dark because it's full of more water because it's inflamed. But also the party trick ultrasound has is it can show you blood flow. It's very good at following moving things because it uses sound. So it uses something called Doppler. That's the same as the noise of the ambulance that shoots past you and changes its sound to show the blood cells actually moving in real time in the vessel. So it pulses. You can see this. So this is an inflamed joint. It's swollen here, and there's all this extra blood flow. And you can also see, sadly, perhaps the damage that the arthritis does to the joint. So this is where that inflamed tissue has burrowed into the bone and it's eating away these things that we call erosions into the joint. And of course, if you don't control that, then you're going to end up with damage to the joint, which you can't easily fix, and deformities and disability. So I'm going to illustrate that because goodness knows we need a real world example. And this is a true example, something that I was confronted with a few years ago. So as you go to medical school, some of your friends do things like becoming GPs. And so one of mine did, and he asked me to see a patient of his. And his patient was an elderly gentleman who was just sorting out his garden at the end of the year. And he was gathering together his bamboo canes and just shoving them in one corner, bound them all together and shoved them in the corner of the garden. And he felt a pain in his finger, but he couldn't see anything obvious going on. So obviously this isn't him. This is a highly paid actor who's sorting out his garden, and these aren't his real bamboo canes, but you get the picture. But these are in fact his real fingers. So these are his index fingers stuck next to each other. And you can see there's quite a big difference between the one side and the other, isn't there? So this is on the sort of back of the finger, and this is on the pulp space of the finger. You can just see it's a little bit swollen. It was quite painful, and he couldn't bend it at all. He couldn't move the end of his finger. So he went to the hospital, he went to the A&E department, and they looked at it, couldn't see anything wrong, did an X-ray. This is the X-ray. Couldn't see anything wrong with the X-ray. Sent him home again, came back again. This time it was a bit redder, a bit more painful. They gave him some antibiotics, the redness went away. Still painful, still couldn't bend his finger. So he sent the patient to me saying, he can't bend his finger. What's going on? So ultrasound is fun in this sort of space. What ultrasound's good at is, if there's a problem in a specific place, you will find it. So this now is looking at his finger. And what I'm doing as the way ultrasound works is you cut a slice through things really. So if you imagine I'm cutting a slice through the end of his finger here. So this is what it should look like normally. There's some bone here inside the finger. Then this is just the normal structure of the finger with a skin over the top. And what you'll notice here on his finger is there's this dark area. So that looks a bit like the swelling, and that is swelling. And there's this little white prick of light here, which is very bright, much brighter than this other funny grey stuff, which is just the normal fatty tissues under the skin. And when you look at the Doppler signal, you can see there's blood flow everywhere. So it was really, really inflamed, even though it didn't look that exciting to look at the patient. But the fun comes when you turn the probe around and you look along the finger. So when we do that, we have a very different view. So again, here's the normal joint at the end of the finger. You can see it's quite dull, quite boring, not much to see. There's a tiny little joint space in here and 2 bones. What he had was, if you look at this scale, this is about 2 centimeters here. So he had the best part of 1 inch of bamboo stuck inside his finger that had gone straight through the skin. The biggest splinter you can imagine, basically, and that was splinting his finger. So he couldn't move his finger joint because there was 1 inch of bamboo stuck there, stopping it from moving. But you can see there's bits of fluid here. There's all this inflamed tissue around it. And again, all of this blood flow is really exciting. You think, wouldn't it be nice to know what's happening in there? The great thing about this was that having shown this to the surgeons, they went, oh, they did our operation, took it out. And then you can do what you do with tissue. You can cut sections out of it. So here's a cross section of that tissue that I saw. Here's a little cut section. Here's the bamboo. That bright point is that piece of bamboo. And here you can see, just like I showed you with rheumatoid arthritis, there's all these little blue round cells in here that are invading the space. And all the blood flow is going through these little tiny white bits. Yeah, these are the blood vessels. So it's very rich. Again, it's a bit like if you'd stung your finger with a wasp, all this inflammation's going on. And that's quite a generic response. And it's the difference between these types of inflammation, different diseases, which give us the clue as to how to treat them. Okay, so that's a party trick ultrasound has. And it's actually that sensitivity, so it can see things that neither patients nor doctors can. So if I have a patient with arthritis, then rheumatoid arthritis in particular often affects multiple joints. And one of the ways you diagnose it is by seeing, well, how many joints are there? Is it symmetrical? So this is a real patient. So this typical patient came along. And when we asked her how many of her joints either were painful or swollen, she said, well, all of these ones hurt. These are all affected by my arthritis. Then we've got a doctor to assess, and the doctor doesn't feel the pain. The doctor can only kind of squeeze the joints and work out whether they're painful or not and ask the patient what they think. So it can find out whether they're swollen or tender. So typically they find less joints. They're being a bit more specific in their assessment, but we've gone from 7 joints down to 3. But actually, if you scan, you can see involvement of all of these small joints. And there's more than 20 joints here that are inflamed if you actually use a sensitive enough method. And we can use that. And actually, we used it just recently in a clinical trial. So this is the PIPRA clinical trial, one of those useless trial names that makes no sense. But the point of this trial was to see if we can prevent arthritis before it really gets started. So you may have heard of people starting to do clinical trials in children to prevent diabetes, and this is exactly the same sort of thing. So what we did was take 200 patients and we split them into 2 groups, because in a clinical trial you have to compare one treatment with another. And we took patients who only had pain in their joints. They didn't have any swelling. As far as we knew, they didn't have any inflammation. And most of their blood tests were normal, the ones we look at for inflammation. The only ones that was positive was an antibody test that we see in some patients with rheumatoid arthritis. So we knew they were at risk of developing arthritis, but they didn't have it yet. So we split them into 2. Half of them got quite an advanced treatment that we're only currently using, quite advanced rheumatoid arthritis. So it's quite powerful. It's an antibody treatment that switches off part of your immune system to switch off the arthritis. But we compared that to patients who were given nothing. And that's because actually we don't normally treat these patients at the moment. We don't exactly know what to do with them. We know they're at risk, but we don't know if we can affect the arthritis or not. And we assess them regularly, both kind of clinically by squeezing their joints, but we also used ultrasound. And the reason we did that is we wanted to know exactly when the arthritis started. We wanted to use the most sensitive method to measure when those joints became swollen, partly because we just wanted to know that very precisely, but also partly because when that happened, we want to treat the patients in a hurry. So it's very important to us not to have to wait until the patient was really struggling to get out of bed in the morning with terrible swollen joints. So I'm going to show you what that allowed us to do using all the sensitivity of ultrasound. So here's that same scheme, but now what you're seeing is the results of a study. Okay, so there was a year of treatment, and then there was a year when we stopped all the treatment and just watched what happened because we didn't know what would happen. So the red line here is the placebo. So these patients effectively had no treatment. And in that first year, a quarter of them developed rheumatoid arthritis. So this number is the number of healthy people that's dropped by a quarter over time. And that's exactly what we expected. We didn't expect all of them to develop arthritis. So a quarter of them did. But the patients who had the treatment, this was amazing. So very, very small number of them developed the arthritis. Really big effect size, bigger even than we were expecting. And then when you stop that treatment, which you have to do, actually progressively, most of them developed arthritis. So these lines don't quite converge. What you can say from this is that actually, yeah, we can at least delay arthritis. We can't cure it at the moment, but we can absolutely delay it. So this is causing big questions for us. So can we improve this? Can we predict who are that quarter who are going to develop arthritis? But it's really exciting. That means that for some patients, we may be able to stop them from ever getting their arthritis. We just need to use the right group and use the right treatment. This is really exciting. Okay, so I told you about using ultrasound to see what's happening in the joints and how we can use that. But the other thing I talked about was, can we use the vision of ultrasound to allow us to take samples from the joint and to give treatments as well? And we do that routinely, actually. We've been doing that for quite a while in Birmingham. We're ahead of most centres in this respect, but particularly centres in Birmingham and London do a lot of this work. And what we do in this case is we use the ultrasound scan to allow us to miniaturize what the surgeons do. So if we wanted to take samples for research from a patient to do a clinical trial or to understand how the arthritis is working, you wouldn't want to have an arthroscopy. That's quite a big undertaking. You have these things that it's called keyhole surgery, but the things that surgeons would refer to as scopes. But they're quite big. They're quite big metal items, and you need 2 or 3 of those in your knee. So you'd normally have a general anaesthetic for that. Whereas in this, we're using the ultrasound probe to see where we're going. And then we're just using one very tiny plastic tube to allow us access into the joint. And we're using little tiny miniature needles to take samples out of the swollen area of the joint. So this is really exciting advanced work. And the size of the samples we take is literally smaller than a pinhead. It's absolutely tiny. Okay, so why does that make a difference? Why is that important? Well, for many years, we've done research with patients looking at their blood. Sometimes we'll even take fluid out of the joints. We'll look in their urine. We'll look at anything we can get our hands on easily. But none of those things have really told us what's happening inside the joint. So sometimes you have to actually go inside and take samples out to understand that. And actually, if you think about that in other diseases, if you think about that in terms of cancer, or if you think about that in terms of inflammation in the bowel, you'd be pretty surprised if you developed a lump in your body if the doctor said they're going to give you some treatment, but they haven't taken a biopsy. They haven't found out what's happening in the tissue to tell them what sort of tissue they can use. I mean, you'd be pretty impressed by that or pretty amazed by that. And some of the treatments that we use to treat rheumatoid arthritis are quite expensive. They cost about £10,000 a year. And yet we don't do any tests to work out which one we should use. So this is the start of a new era for us, in which, because we can use this type of procedure, we can really routinely take small amounts of tissue out of the joint, and it really changes what we can see. So it's not just about seeing in the same way as we do with ultrasound or seeing in this way. This time it's about seeing what's happening to each individual cell in the body. So before we started this work, we could take samples out of the joint, and we'd do this sort of thing where, again, you take a section of it just like we did with the bamboo in the finger joint, and you stain it with this pink and blue stuff, and then again you can see there's lots of different types of cells. And we kind of had an idea that there were a number of different cell types. We knew there were some white cells, we knew there were some cells which eat invading cells, we knew there were some structural cells like bricks and mortar called fibroblasts, and we knew there'd be cells in blood vessels and things like that. So we guessed there were maybe 10 or 15 different cells. But using newer technologies, these have been available for about sort of 7 or 8 years now, called single cell sequencing. You might have heard of DNA sequencing. Well, this is taking each individual cell, and there might be 1 million cells in your joint, And then we read out which genes each cell is using, which ones are switched on and which ones are switched off, and that allows us then to identify different cell types. So it was a bit of a shock, but actually there aren't 10 different cells in the joint. There's at least 80 different cells. And that gives you a phenomenal scope to understand disease. But more importantly, you can identify which are the bad ones and which are the good ones. So I could tell you from what I know now, that this murky green, khaki green number 4 here over this is a nasty cell that eats other cells and other structures, and that would be a great cell to knock out. We could switch that cell off, or we could switch off the things that it produces and block them. And over here is another type of white cell called a T cell. This one here, we learned about quite early on using this technology, and we've just completed a clinical trial giving something that blocks this cell to patients with rheumatoid arthritis, and so far it works. And we've done that just in 5 years, which sounds like a long time, but it's a very short time for going from a sample to finishing a clinical trial to prove that something works. So we've got 80 different bites of this. That's really exciting, but just in the last 3 years now, we've got yet another tool to help us with this. And so if we go back to here, this method here, the sequencing works by taking the tissue and actually digesting it. We take the individual cells out of the sample, and we get rid of all of the fat and all of the gristle and stuff like that, and that allows us to look at the cells. But when we do that, we've lost where the cells are. And a really important aspect of what cells do is they talk to each other. So it's not usually a single cell that causes your condition. It's a group of cells. We might think of it as a neighborhood, like the suburbs of Birmingham, for instance. It might be Solihull, it might be Sutton. It's neighborhoods of cells that cause disease. So this is a new thing called spatial transcriptomics. So in this case, you're going back to these little slices of tissue, but now you can look at the genes they have switched on the actual tissue itself. So now I can see those 80 different cells, but I can see them all right next to each other. I know which cells, sat one next to the other. So I guess I'm going to use a footballing explanation here. So I guess in the old days, we could kind of see this. We could take a bit of the tissue out, we could look at it and go, oh, that looks pretty bad. So, 2-1 to Sunderland. Apologies to anyone from Sheffield or Sunderland. It's a random match from last year. That's great. And this stuff here, now single cell sequencing, this is great. We take the cells out, don't forget. So we have lots of little cells in a pot, and we can work out which one should do what. And so that's a bit like seeing the lineup. The trouble is it doesn't really show you the game, because we can see what they should be able to do, but we don't actually know how they play together. So this new technique, spatial transcriptomics, this is amazing. This is a bit like watching the match live. So you can see literally who's tackling who's scoring the goals, and what the team structure is. So really exciting advances. So I'm just going to show you an example of one study that's actually running on at the moment. So if you had all of that ability to understand what's going on in the joint, you could see what each individual cell was doing, which one was doing which job. What question would you like to answer? Well, the question I wanted to answer was this one. So it's when you take a patient and you're already giving them treatment, this is happening all the time right in front of us. So rather than running a clinical trial where you're testing treatments, why don't we look at the patients who are already taking treatments? So one of the issues with this is that I've got a list of 3 treatments here, something called TNF blocking, IL-6 blocking, and something called JAK inhibition. And these are some of the advanced therapies we use routinely. But probably only about 2/3 of any group of patients will respond to these treatments. So, for each 100 patients, maybe only 60-70% will respond, or 60 or 70 will respond to each treatment. The others won't respond at all. We don't have a test, you'll be amazed to hear, which tells us who's going to respond to which. And so the purpose of this study is to take some samples before the patient has before they start their medication. And then 3 months later, when they've been on their medication for a while, they'll either have got better and responded, or they won't have responded, they'll still be struggling. So then you take another sample. So what that allows you to do is answer this sort of question. So we can start to look who will respond. So we can start to predict who might respond by looking at the tissue at the baseline and then seeing how well they do. And then not only can we do that and predict, but we can also look later on and find out, well, why is it that some patients don't respond? Why do some patients not change at all when you give them an expensive therapy that should work? And the really exciting thing is then you can look into the tissues of those patients where they haven't responded, and you can say, okay, well, it wasn't that one, but actually what treatment should we use? So it's a really exciting era that we're getting into now. So this study's going along at the moment. So we take these samples out routinely, and then we do these tests with them. And the only issue about this type of test and this type of an analysis is that it generates enormous amounts of data. So you need a new type of scientist really to analyze this sort of data, because you're generating such a lot. But it's very rich and exciting data to work. Okay, so in summary, what I've shown you that we're doing in Birmingham at the moment is that we use ultrasound to detect arthritis early. So we actually use that sensitivity to detect it, not just in clinical trials, but actually in the clinic as well. We'll use ultrasound to see what's happening in people's joints. We use the ultrasound to allow us to take tissue samples that can now allow us to fully understand what's happening in arthritis and develop new treatments and test them out really quickly as well. And for another one of these webinars, because it really deserves one of its own, is we're applying those same principles to take tissue samples out of children's arthritis. And that's a harder job, but it's absolutely fine. Both the children and the parents are absolutely on for that. So understanding that is a very exciting horizon for us now that we're starting to do in Birmingham. Last thing we're doing is we're using all of that technology and all of these samples to allow us to develop personalised therapy and new treatments that are going to be coming available to people with arthritis really faster than you'd think. So we used to think it would take 10 years to get a treatment from development all the way through to patients. That time is telescoping very rapidly at the moment. Okay, so it's an idea of the exciting work we do, and many people help us with this, not least the fact that there's a big team, because these biomedical research centre grants are quite big. They allow us to bring people in who help and coordinate. They've coordinated this, as you know. We have other funders who help us with that work, and one of the important funders that I'd promoted just before is Versus Arthritis, who've given a lot of fantastic charity funding as well. But I won't read through this whole list, but actually it's the patients who participate in our studies that give me the joy of interacting with people on a daily basis, but they also allow us to do our research, which is all based on human samples, really. So I'll finish there.
Oh, thank you very much, Andrew. And that was absolutely fascinating. And I know there are lots of people asking questions as you go along as well. I'm hoping you can see me now, and I've appeared as if by magic, but it's really interesting, because there have been all sorts of questions, some of which really relate to what we were saying as well. So I'm going to start to read them out to you, if that's okay, and get you to answer them, because you haven't worked hard enough doing that presentation. Now we're going to ask you a number of questions, including this very first one that we've had in, and we have had, as I say, a number of them, and some of them are similar to each other as well. This one's about juvenile rheumatoid arthritis. So someone who's had this for a number of years has said, I've not seen ultrasound used in my rheumatology clinic ever, although I was informed it was an important tool. Is it much used in clinic setting? And if not, is this down to funding or clinic time constraints, perhaps?
Wow, that is the sort of question I would expect from a very well-informed patient. You put your finger on it exactly. So ultrasound is something that's becoming very widespread. However, it's not something that's been formally adopted as part of the training in the UK. In other health services, particularly in Europe, then it has been adopted. And you know how things go with NICE and things like that. So it's not routinely present. However, there are a lot of things we're doing at the moment to bring that forward. And in fact, because it's such a useful tool, most rheumatologists, as they're coming through training, are becoming trained in it anyway. But it's not as fast as people like me. So I've been an ultrasound advocate for many years, because it helps me so much in my management of patients. But it's another of those struggles, and it's absolutely one of those questions of, okay, in a limited health service, are you going to have ultrasound for patients with rheumatoid arthritis or patients with JIA as well? Or are you going to have another MRI scanner for cancer or another condition? So you always have to make those arguments. But the more we scan, the stronger the arguments get. So it's really down to us as a community to publish the studies and show that it actually makes a difference. One of the nice things about ultrasound is they are getting cheaper all the time. It's one of those technologies that always improves all the time, like just like computers, because a lot of it is based on the speed of computing. So ultrasound is always getting cheaper, so it will become more available. The machines are getting smaller. I almost showed you the Star Trek picture of Bones with his little tiny sensor linked to his machine that he used to have, and we've pretty much got those. So some of the ultrasound machines are just a probe that just talks to your phone. They're not even that big, massive whirring machine that you're used to. So it's only a matter of time.
Okay, thank you very much. We, I mean, sort of related to that as well, very nice comment saying, superb presentation. Some clinics use handheld ultrasound machines at a bedside or during routine checkups. Do you see a future where arthritis scans could become as quick and common as having your blood pressure taken? So I'm kind of guessing what you might say here.
Ooh, well, no.
Oh,
Warren, what an awesome question. You're all very well informed, which I guess is what I'd expect for this type of webinar. So I guess 2 points. One is, yes, they are getting smaller. The handheld standalone machines, though they're lovely, are not quite as good as the big machines yet. So although they're quite portable, they don't give you quite the quality, but that is absolutely just a matter of time. I mean, I'd give it maybe 5 years and they'll be pretty much as good as. So that's nice. The other thing is skills. So you do need to be quite skilled to use ultrasound kind of live in the clinic, just like that. And that's really exciting, right? So we've actually done some research on this. So you think about how you normally have an X-ray test. So you see the doctor in clinic, your GP, or you see a consultant, and they say, oh, you need to have a scan, Mrs. Jones. And then, a few weeks later, you get an appointment for a scan. And then 3 months later, you go and see your doctor and they say, oh, I've had the scan results now. That's not a very satisfying way to use ultrasound. So as it happens, when I'm in clinic, I have a scanner next to me, and so I scan it straight away. I answer my own questions, and because I'm experienced, I'm good at it. That's not so easy for everybody to do, and GPs definitely can't do it. It would be too many things to ask them to do. So we are doing some research on this, and it's not research as in, how does it work? It's very practical. So AI is making a far bigger change to imaging, ultrasound, MRIs, CTs than it is to other parts of medicine. And that's because there's many things you can automate. And one of the things we're automating is getting the images. So if you imagine you can just have a probe and you can just wave it over the joints instead of having to find a very specific view, then it'll find the right images for you and it'll also grade them at the same time. So we're working on that at the moment. And then that takes out the biggest problem. So the biggest problem is not having a machine. The biggest problem is having people trained in the expertise. If you automate that, which is quite possible, then that makes it a lot more accessible.
thank you very much.
Next stage.
Okay, next question then. So once the arthritis is set in, can the treatments you've mentioned work on any kind of arthritis? I ask this because of injury to my knee and hip, and the morphology and injury of the joints has caused it to degrade.
Yeah. So you've put your finger, in fact, you put your knee on the problem of sort of osteoarthritis. So that's sometimes not helpfully referred to as wear and tear, though I think we all sometimes understand that. And that's because when people have joints that are damaged, they're much more prone to develop osteoarthritis. But actually osteoarthritis, as you'll know, also affects people with age. So enough of that. There are many different types of arthritis, and some parts of what you see is shared. So every type of arthritis will have it. So in fact, that swelling of the lining of the joint you see in all cases. The differences are much more subtle between different conditions. And that does mean that you can aim specific treatments at different diseases. And it's understanding, it's actually taking samples from all of the different types of arthritis that then allows you to aim, the correct treatment at the correct patient. So we're probably most advanced with rheumatoid arthritis, and that's because it's the commonest joint disease that has the most inflammation. You'll have realized that with osteoarthritis, we're not actually that well. We're very good at treating it, but we only treat it once your joint is so damaged it has to be replaced. So for knees and hips, joint replacements are the best operations we do in the NHS. They're so cost effective, they're very effective, but my goodness me, you don't really want to have to replace the joint, do you? But applying exactly that type of technology I was talking about just now, where you take the tissue out and you understand what's going on at the cellular level, there will be advances with osteoarthritis very soon. I can promise you that. And then what we'll then have is a slightly different problem, the problem you want to have. So you'll have noticed all of the excitement about drugs that help people to lose weight, that were developed for diabetes. They help to push glucose sugar back into cells. But as it happens, they also make you feel full, and they reduce your appetite, and people are just using them in their millions, to reduce their appetite and lose weight. So when we do, and we will find drugs that slow down osteoarthritis, then we'll have the problem of how can we produce them cheaply enough to use, because almost everybody develops some osteoarthritis eventually. And then so the balance will shift to partly affording the treatments, but it also shift to, well, how can we predict who's going to need them, because it's a slow process. But it's not entirely fair to call osteoarthritis wear and tear. It's actually another inflammatory arthritis that we're just not so good at treating.
Thank you.
Probably enough.
We've got a few more questions to go through, if you don't mind. How is genetics measured in a study? Does it make a difference? And also a lovely comment saying, great presentation, thank you.
Woohoo. Yeah, genetics are fascinating. So all of the conditions I treat have a genetic predisposition, but that means that the genes don't give you the disease directly. What happens is you are born and you'll have a greater or lesser predisposition to developing a particular type of arthritis, and you know that because people often have family members that are affected as well. In fact, if you think about families, it won't surprise you to know that the strongest genetic links are actually for osteoarthritis. So if you look at your mother's bunions on her feet, sadly, that's probably what you're going to get. So osteoarthritis is very strongly genetically coded, but it doesn't automatically pass. And that's because you have genes that predispose you, and then you do other stuff, or other stuff happens to you. So this idea that there's genes and then environment happens to you. And that's for rheumatoid arthritis, that's really clearly known, particularly for smoking. So if you like bad genes, they're good for other things, but they predispose you to rheumatoid arthritis, and then you smoke, then you massively increase your risk of developing rheumatoid arthritis. And that's if you ever smoke. So, smoking we know is a bad thing, right? So that's not that exciting, is it?
Yeah. Sort of connected to that, we've got a question saying, you mentioned the link between cancer, arthritis and diabetes. This particular person said that all those conditions were in this person's family, along with Parkinson's and Alzheimer's. Are studies being undertaken to identify why this is the case and what treatments are available to combat the devastation these conditions cause?
That's really exciting. There are massive changes happening across the board, really. And it is, again, this type of study that's allowing that to happen, understanding what individual cells do. So Alzheimer's and Parkinson's we think of as kind of neurological diseases, but maybe Parkinson's disease, in the brain is rather like osteoarthritis in the joints. So once you start to look at these, and people are increasingly doing this, they're almost creating atlases. They're creating atlases at the cellular level of healthy tissues like the brain or the joint, or the kidney or the liver, and then they're collecting the data, because as each researcher does their work, then we're obliged, when we publish that work, to publish the data as well. So the data has to become publicly available. So you may not know this, but when you publish a paper, you think, oh God, those scientists are publishing papers again. But as a condition of doing that, we have to post the data. So a large part of the future of medicine now is coming from the fact that people have to publish it, and then you can put all these data together and start saying, it's a bit like the UK Biobank project. You can start to say, well, we've got data on 5,000 people now, and we've got data on 20 different diseases. And so treatments that we were using for Alzheimer's disease, or maybe treatments you're using for rheumatoid arthritis, actually, you could be using an Alzheimer's disease. And that happened recently. So we know quite a lot, again, about the cells and the mechanisms that happen in rheumatoid arthritis because it's common and because we've spent a lot of time on it. Multiple sclerosis is really tricky, as you know. A lot of neurological diseases are really difficult to treat, and that's partly because you can't really get into people's brains very easily. You can scan them, but it's really hard to take samples. But actually it was realized from doing some of this very, very fine work, just taking cells out of the cerebrospinal fluid in patients with multiple sclerosis, that completely unexpectedly, one of the mechanisms that you see in rheumatoid is also seen in multiple sclerosis. So you could think of MS, horrible disease, as rheumatoid arthritis of the brain. So for some patients with MS, if they have those cells, you can switch off their disease really nicely with a treatment. And it's only again in the last 5 years that's been discovered. So it's a very, very hopeful future. And in a time when everything seems a bit negative, people are trying to kill each other and things like that, medicine is so exciting. So what you're looking at is maybe when the Human Genome Project happened, I remember this happening, it's a while ago now, isn't it? There was a lot of fanfare about it, but I'm not sure we heard a lot about what was coming out of it. I was quite disappointed, really. It has been quite quiet. But what you're seeing now is this second wave of where the technologies allow us to see what's happening at a very, very fine level. And then you're reading that from the Human Genome Project. You needed both of those things, but now everything really starts to accelerate quickly. So although it's a bit of a depressing time in some ways, there are going to be phenomenal advances in medicine in all of our lifetimes very soon. It's a very exciting time to be alive. So, you know, don't be too disheartened by all the conflicts going on in the world, because the science will continue to happen.
What a lovely message. Once you can, so the next question, once you can tailor DNA treatment, do you think will it be offered to people who are and have been on methotrexate for years?
Oh, yes, absolutely. So that's a really interesting question, isn't it? DNA treatment. So that could take various forms. So there's something called gene therapy, where you literally alter the genes in someone's body. And, you know, that used to be something that we were very scared of doing as doctors, obviously, because, you know, the way that cancers start is alterations in your DNA. So you have to be super careful when you do that. But there are some conditions that may respond very well to gene therapy, and one of those would be cystic fibrosis, where you can actually introduce new genes into the chest where the main problem is. So that's interesting. And you might have heard of gene therapy actually for unborn children with inherited diseases, which would otherwise kill them. And you can actually literally transfer a healthy gene into them in the womb, and then they'll be born normally. And that's being done for some of the blood disorders, which is really, really exciting. And the exciting thing that's happening for inflammation is this idea that you can put in cells that will then reprogram the immune system. So almost like having a vaccine, maybe. So we're about to start a trial where you take the patient's own cells out, so almost like a kind of bone marrow type thing, but you're taking their cells out of their blood, not all of them, but some, and you're then engineering those cells very carefully, and you're turning the very active ones into ones that actually switch the condition off. And you put them back in again. And, you know, because that's been done a lot now, we're much more confident that we're not going to do anything horrible to somebody. And interestingly, you actually build in a switch to turn off therapy, so that if there was ever a problem, you just give a specific treatment and all the cells just disappear. So it's really exciting. But no, those are being absolutely used, as we often do when we're first starting therapies. They're on the patients who have the most difficult to treat arthritis. So these things where we're kind of really resetting the immune system, we're either putting in cells that seek out other cells that are bad and switch and remove them, or we're re-educating the patient's own cells. Those are all being used in the patients who have the worst, the most difficult arthritis. It's often referred to as refractory disease or difficult to treat arthritis. And we're seeing successes. It's a little bit like this massive change that happened 20 years ago when we started using the biologics. And all of a sudden, people who had bad arthritis, quite a lot of them got suddenly better. So that's happened in my lifetime. I just started in rheumatology when every hospital had a rheumatology ward where there'd be arthritis patients. You can't find it. You can't find a rheumatology ward now. And that isn't because we haven't solved. That's not because we've solved all the problems, but we've significantly improved matters so that patients rarely have to come into hospital to stay because they can't even move. We've made things a lot better, but not good enough. So yes, absolutely, DNA therapies or cellular therapies are coming now. They're literally happening now. We're going to be running perhaps 2 or 3 trials in the next year, having only one in the past. It's really, really accelerating. And they're just as likely to be effective on people who've had multiple treatments. So absolutely, there's that issue, isn't there, that I'm saying, well, on the one hand, you can prevent arthritis in people who are predisposed to it, but that's not much use if you've got arthritis, is it? But there's just as much excitement about things we're using further along. The excitement is shared all the way.
Oh, that's fantastic, because we have got some more questions. I'm just going to pick the last kind of couple of questions. and then we're going to have to end, unfortunately. But these are sort of related too, I think, because on a very different aspect, someone's asked, can antibiotics be injected into joints for cases of, for example, Lyme arthritis or other infection? And if not, why not?
Wow. You can inject anything you want into joints in the nicest possible way. Sounds terrible, doesn't it? And one of the reasons we often don't inject therapies into joints, you might think there'd be lots of trials for that, with things like rheumatoid arthritis, is because actually it's a condition of the whole body. And if you just inject things into the joints, then those joints might get better for a little while, but actually the disease affects the body as a whole. And so you have to treat the body as a whole. In cases of isolated arthritis that just affect one joint, you can do exactly that. You can put in a treatment that will affect that joint and switch it off for a while, just as you used to be able to you can still surgically just remove all the inflamed tissue, which gives you relief for quite a while. Sounds a bit heathen, doesn't it, really? But your question was about things like Lyme disease. So Lyme is an interesting thing where there is an infection initially, but actually the infection changes the immune system, and it's the immune system that has dysfunction, which then causes the later manifestations of the disease. And I guess, again, in the old days, you might have thought, well, that's it, it's too late, the die is cast. But there is potential for this. Lyme disease is a much rarer disease, but there are people who are doing research into that. And again, it's a matter of understanding better what's happened. And if you understand better the processes that are going on, then you may be able to switch some of them on. But yeah, Lyme is a fascinating disease. It's very rare in the UK. It's a tick-borne disease, but very common in certain other parts of the world, particularly North America and Canada. It's very, very common there because there's a lot more ticks, a lot more woodland. So there is research going on. So where we can actually injecting things into joints is great. It's just that usually it doesn't immediately solve the problem.
Thank you. And I think this is going to probably have to be the final one, but we'll see if we can squeeze in one more. And I know a number of people have asked questions about this. What's the role of nutrition in prevention and perhaps helping manage symptoms after diagnosis?
Oh, what a fabulous question. Okay, well, all right. You can tell I tend to talk.
Not mine. It's these lovely people.
No, I know. I tend to talk in, very long sentences, and too many of them. This is very simple. So a good, healthy diet is anti-inflammatory. It can both help to prevent arthritis and it can help to treat arthritis. It is part of self-management of arthritis. And there is a lot of nonsense out there. A good, healthy diet is a Mediterranean diet. So that means particularly things like olive oil, which is very rich in gamma oils, or omega-3 and omega-9 oils. Fresh, unprocessed food. So this whole thing at the moment about ultra-processed food is very right. So anything you buy that's full of ingredients is not part of a healthy diet, basically. If you're working with fresh food and you're cooking your own vegetables, which to be fair are cheaper than processed food, fish is always more healthy than red meat. So red meat is quite pro-inflammatory, I'm afraid. Fish is the opposite, really, because again, it's full of omega fish oils as well. So go and look up a Mediterranean diet and use unprocessed food. And yeah, it is not only properly anti-inflammatory, but if you look at people's diets and correlate it against their disease activity and things like rheumatoid arthritis, then the more inflammation there is in their food, the more inflammation there is in their arthritis. And that's because those things affect your microbiome, that little factory of a few trillion cells that's sitting in your gut. So there's some fascinating research just come out about yogurt type bacteria as well, suggesting that if you treat regularly with live yogurt cultures, you can really improve response to treatment for rheumatoid arthritis, just to normal methotrexate and things like that a lot of patients take.
Yeah, we did talk about this in our last webinar, actually, which was about the gut microbiome, didn't we, with Dr. Peter Rimmer. And again, there is a little bit of, not a little bit, there is research out there, but there is a little bit of snake oil sometimes in people promoting certain diets and so on. You have to be very careful and make sure you go to the science, don't you, really, and go to recommended sites. And I'd recommend listening to that. Yeah, thanks. Well, I'm sorry, I'm going to have
wonder
to.
what sort of diet to have. have a diabetic diet. That will always be, the healthiest thing to have. There's another reason why high sugar is also pro-inflammatory as well. Anyway, enough.
Yeah, no, absolutely. I mean, that's solid advice. Thank you so much for sharing that. I'm going to have to draw it to a close, really, or else we'll never stop because the questions are coming in. But you've answered those brilliantly. Thank you so much for doing that. There was a question which I didn't get time to answer. I'm going to touch on it, if you like, hopefully in this, because you acknowledged at the end of your slides, actually, the people who've been involved, and also you acknowledged the patient partners that you've worked with as well. And, this is, and a number of the people joining today's call, I happen to know them. They're in public and patient involvement groups that we work with. Some of the people aren't already. So again, I'm just going to make sure that everyone's absolutely clear. You can take part in research. You can be someone who volunteers to be that subject. You could be someone who wants to be part of a trial or some kind of clinical trial, which, Andrew has explained just how important that is for us to learn from and to be part of. So you might want to go to be part of research. And again, you'll get links when we send out all of this to you as well. And it's been put in the chat now as well. You can see if you click on that chat, it'll put you onto their, your browser will take you to that site. And again, they look for healthy people as well as people perhaps who might have a disease already. And that was something that someone asked earlier. And if we look at the next slide, you'll see we actually do have, and some of the people on this call are people potentially in this photo that you'll see about get involved. So we've got people who are not going to be perhaps in a clinical trial, but actually want to help design and work with someone like you, Andrew, to help design that trial in the first place. So if you can see here, we've got photos from different events that we've done, and we really need people to have their opinion, to ask these fantastic questions. We need to hear from you, and we can provide training, we can get you into groups, we can get in one-off things. There are a variety of different ways that you could be involved, and just have a look at our website. We're going to put the link in, and you can see if you look on our website, for instance, here, about how you could get involved with the Biomedical Research Centre, and you can learn more about that. You can see what you're stepping into. You can ask more. You don't have to join straight away. You can lurk, you can watch and see if it's for you. But again, we do need people from all over the community to be part of the research that we do, because we know that our researchers are fabulous. We know we've got lots of specialists. We've got people in really skilled specialist areas, but we also need the public and people with that lived experience to be part of it. So we'd love you to think about joining if you're not already. We'd love you to tell other people about this and share with them, the things that you're learning. And we'd really like to hear from you in terms of the feedback for today's webinar, to see whether or not this is the sort of webinar that worked for you. If it didn't, why didn't it? We're learning all the time, and you wouldn't expect anything else from a research active centre, would you? So we would love to see you at our next talk. We're going to have a couple of months off, break for summer. So a lot of people will be away, and then we'll be coming back in September with some fabulous talks. And again, we'll be advertising those in the way that we did already. And again, if you sign up and say in the feedback form that you want to be involved, want to hear from us again, we'll make sure we do that and share with you when we've got more coming up. But in the meantime, I'd like to say thank you very much, Professor Andrew Filer, for your brilliant talk.
Pleasure.
Loved hearing from you. Thank you very much. And thank you very much for everyone that put questions in and everyone that attended. And I'm sorry we couldn't get to all of them, but we're going to end it now and say, take care, have a lovely evening, everybody, and hope to see you all again in the future. Thank you. Goodbye.